In case you're wondering how I got into the coroner system, I used to do pharmacology consults for the coroner's office, and after every time you do one, you get checked in and get a police check and sworn and everything else. I just got tired of doing it. So why don't you just become a coroner? And I said, sure, why not? So I did. So our objectives are three: to understand the structure of the coroner system in Ontario, to understand the basic principles of the Coroners Act, and understand how and when to call the coroner. So 2 cases to consider in the ED, 2 based on actual cases. So 76-year-old gentleman out for a drive with his wife when he collapses. Pulls the car over. EMS is called, and they start resuscitation at the roadside. Ventricular tachycardia is found in a rhythm strip. This gentleman has had a history of angina, has had a stent placed, brought to the ER, resuscitation is carried out, but is unsuccessful. Second case, 8-year-old girl presents with a history of high fever, being found unresponsive by her parents. On examination, temperature is 35 degrees centigrade, has a widespread petechial rash, unresponsive, tachycardic, and hypotensive. So therapy is started, but becomes asystolic, resuscitation is unsuccessful, and expires in the ER. You call the coroner for one case, both case, neither case. So, what is a coroner? In Ontario, a coroner is a physician who acts under the jurisdiction of the Coroners Act to determine the cause of death in the case of unexpected death or deaths under special circumstances. And the coroner is part of a death investigation team which includes specialists, technicians, the police, and regulators. Coroners are not crime scene investigators, we're not medical examiners, and we're not pathologists. What is a definition? The definition of a coroner, this is derived from medical dictionary, either presiding officer of a special court, a medical officer, an officer of law, responsible for investigating deaths, particularly under unusual circumstances. In the case of the Ontario coroner, it is the latter that which applies, which is to say a coroner is an officer of law responsible for investigating deaths, particularly those under special circumstances. If you go back to the Statute of Westminster, which predates the Magna Carta, the Statute of Westminster is one of the bases of English common law. Citizen is bound, the subject actually in that case, was bound to issue the hue and cry, call for help, which calls for 2 officials to respond, the constable to look at criminality and the coroner. And the coroner's goal originally was to establish circumstances of death, and this had much to do, to be blunt, with the fact that in circumstances of suspicious deaths, property and assets revert to the Crown, hence the name coroner. The Crown's plea initially was looking at things, because the idea was if you can't benefit from an illegal act, so the Crown should benefit from it. So it's evolved subsequently. So coroners in most jurisdictions are people that are involved with death investigation. The Coroners of Ontario are charged with the investigation of unexpected deaths. The motto of the service is speak for the dead to protect the living. And a coroner is an officer of law. So despite the fact we're all physicians, we actually do not operate under the auspices of the Ministry of Health and Long-Term Care. We operate under the auspices of the Ministry of Community Security and Correctional Services. We're actually empowered that way. We have badges that have badge numbers on them. We write warrants. We can't arrest people, but we can ask people to arrest people. And we're empowered under that statute to investigate deaths. There's roughly 80 or 90,000 deaths a year in Ontario, of which about 20,000 get investigated by the coroner. And the coroner systems across North America are quite varied. In Canada, they're provincial, so each province, each territory has its own coroner system. In the U.S., they're done by the county. So in the U.S., there's about 3,000 coroner systems. So the Ontario coroner system is the largest coroner system in North America. It has about 330 coroners. In most of the U.S., they're done by the county. And there's quite wide variation in how they operate. Most U.S. systems use a medical examiner model in which the coroner is often a layperson, typically a layperson, and the death investigation is primarily done by the medical examiner, which has implications. In Canada, there's various models. There's 2 physician models. Nova Scotia and Ontario have a physician-only model. The other provinces don't require you to be a physician, although to be frank, a lot of coroners in other provinces are physicians, but it's not a mandate. The Coroners Act in Ontario defines what coroners are and what they do. And it was defined, the Coroners Act was actually last amended in 2009. And for those of you who actually want to read it, that's actually the email link to the Coroners Act. It's quite long, like many pieces of legislation, it's long, it's detailed. But it sets out what coroners can and can't do. So as I said, we have an all-physician coroner system, and it's done on a regional basis. There are 8 different regions in the province. We're in the West region, which sounds a little odd if you look at the map of Ontario and think, why are we West? Because there's a lot of Ontario west of us, but that's counted as the northern region. In London, there's 8 of us, and there's a regional chief coroner, which is Dr. Rick Mann. So the way the system works is organized. There's a chief coroner, there's a deputy chief coroner, and there's a series of regional chief coroners that are all full-time positions. So there's about there's also a chief forensic pathologist as well. So there's about 11 positions that are full-time positions. Everybody else is a part-time physician. Most coroners in Ontario are family doctors. There are 3 pediatricians. I'm one of them. There's a few people that do other things as well. A fair number of people who actually become chief coroners are actually emergency physicians. So if you look at Andrew McCallum, the previous chief coroner, the one before that, we're both emergency doctors. So a number of actually coroners' work is something that actually attracts a number of people in emergency medicine, especially people who get higher up in the system. So to become a coroner, you have to have an Ontario license. So how do you do it? You apply to chief coroner's office, and then you undergo an application. You go to an interview. You go a police check. So if that all pans out, then you take the coroner's course in Toronto. Once you take the coroner's course, you pass the coroner's exam, and then every 3 years you get recertified and retrained. Reasonably rigorous. They have a lot of CME. I must say I get probably a CME thing from the coroner's office about every 2 weeks to keep up on new trends and new legislation, etc. So there's actually pretty rigorous on this. How do we conduct investigations? Under the Coroners Act, and the Coroners Act defines under Section 10 what should be investigated. This is a clip from the Coroners Act, but it says an investigation, this is a literal reading from Section 10. You should conduct an investigation if a deceased person died as a result of violence, misadventure, negligence, misconduct, malpractice by unfair means, which is the interesting, what does that actually mean, by unfair means? That's the kind of slippery slope in the Coroners Act. During or following pregnancy, suddenly and unexpectedly, from disease or sickness which are not being treated by a physician, from any cause other than disease, or under such circumstances which require investigation. There's things in which it's clear. So if you're not sure what's happening, if you think it's a homicide, a suicide, or you're not sure what happened, that should be investigated. Certain hospital deaths have to be investigated. There's typically post-accident. There's other circumstances. All motor vehicle accidents require investigation. Any railway accident requires an investigation. That's actually a joint investigation because the railway safety authorities are involved in there well. Industrial accidents are any death involved in an industrial accident, it has to be investigated, which also mandates the Ministry of Labour to be investigated. Children under age 5 and certain deaths in certain institutions. So a provincial hospital. Most provincial hospitals are mental health facilities. So any death in that facility, or certain nursing home deaths. If there's an outbreak, and a death is believed to be due to an outbreak, it's investigated, or a threshold death. And a threshold death in a nursing home is every 10th death. It's been debated about getting rid of it, because the idea is that it's not that useful. Personally, the feeling is that it's not that useful an index. Because the idea behind threshold deaths was, if the John Dwyer nursing home has 1 death, has 10 deaths in 2 years, and the Gary Gilbert nursing home has 10 deaths in 10 days, there might be a difference in what happens in those nursing homes. Maybe they have different patients, maybe there's different quality of care, who knows what. But and that's not a bad idea. The problem is that in practice it doesn't work out that way. And the idea was it's better to have Ministry of Health and Long-Term Care has these nursing inspectors that are supposed to go in and inspect nursing homes. That would be a better index of quality. The problem with that, as we all know, is that never happened. The determinations you make as a coroner are a couple, but first is manner of death. And the manner of death is based on how the death occurred and has implications for what goes on public safety. So there are only 5 ways to die in Ontario. You can either die of natural death, accident, suicide, homicide, or undetermined. The vast majority of deaths, unsurprisingly, are natural. Accident is clear, and accident refers to anything which antecedents it. So if you die as a consequence of an accident that occurred 10 years ago, your cause of death is still accident. Ontario, for a while, had a very low rate of suicide officially because there was a judgment called Costello that occurred about 10, 15 years ago in which something was probably a suicide. It was called not a suicide because the family contested it in court. And it meant we, for a very long time, had a very low bar, a very high bar for calling it suicide. So if someone was found with a note and a clear method and had told their friends about it, short of that, it was undetermined. More recently, it's been assessed as probably not a realistic standard because we had a very low rate of suicide and a very high rate of undetermined deaths. You have to have a standard of suicide that applies to other deaths. So our suicide rate is inched up as we were tending to find more deaths correctly with suicides, and the undetermined rate has crept down. Homicide is when somebody kills somebody else, and homicide is not a legal term in terms of like murder. Because if someone, so Dr. Gilbert decides to go drink with Dr. Dreyer at a bar. So they get in a dispute about the outcome of the game, and in a peak, Dr. Gilbert gets a broken beer bottle and kills Dr. Dwyer. The police respond. Dr. Chabert goes after the police officer with a broken beer bottle who shoots him dead. So the cause of death in both cases is homicide. In the one case, it's murder because you purposely killed that person. In the police case, it's what you call justifiable homicide. So murder is a legal charge. Homicide just means somebody killed somebody else. And finally, undetermined. Undetermined happens when somebody doesn't know what happened. And this is not uncommon, that something happens in which you're not actually sure what happens. So the classic example of this is someone who's has a history of substance abuse, and is feeling a little sad, is found dead at home with a quality of recreational chemical. And you don't know if they meant to overdose, if they inadvertently overdosed. You don't actually know that. So that's undetermined. So who can call the coroner? In theory, anybody. Because the Coroners Act says any person. It doesn't say a particular person. In practice, it's usually police or medical or nursing staff. And when you call the coroner, then they have to act how to investigate. So what's the process? Coroner's dispatch is done centrally in Ontario. We used to do it locally, but it's been switched to central. So the coroner's office in Ontario at 1-855-299-4100 is staffed 24 hours by dispatchers. If you call and say, I have a concern about the case, I want to talk about it, they will get in touch with the coroner. They do not make decisions as to triage. Every call they make goes to a coroner. So when a coroner gets a call, what do? The first thing you have to do is decide if it's a case or not. If it is a case, then you have to visit the scene, examine the body, and determine what more is needed. The first step is discuss what's going on. Because if you look at the average call, I would say of the calls I get as a coroner, probably I actually investigate maybe a third or a quarter of them, which is about right. If you think 80,000 deaths, only 20,000 are investigated. You have to discuss with the caller to see if that's actually the right person. So as an example, if an elderly patient in a nursing home passes away of dementia, has known to have dementia, that's not a coroner's case, unless it's a threshold case or an outbreak. So in that case, the person to pronounce it is actually the nursing home's physician. If you think it is a coroner's case, then the coroner is obligated to visit the scene and examine the body. And
just ask a question. Once he's decided is it a potential coroner's case? If he visits the body, or is it an absolute coroner's case?
That's a good question. So if you come out, is the coroner's case or not? Theoretically, the coroner could assess the body, say it's not a coroner's case. The coroner goes, it's going to be a coroner's case. I mean, theoretically, no, but it practically not. So if the coroner goes out, the coroner visits the scene, examines the body, there are a couple of jurisdictional issues. Jurisdiction in any death investigation belongs to various agencies. In the hospital, as an example, the hospital owns the ER. The physicians are independent practitioners, but the body belongs to the coroner. So in a crime, as an example, the police own the crime scene, but they don't own the body. That's the coroner's. The only establishment are Her Majesty's defense establishments, because Canadian Forces establishments don't actually operate under the Coroners Act. They're under the jurisdiction of the Corps of Military Police. That being said, the Corps of Military Police has no forensic capacity. The reality is they actually cooperate closely with the coroner's office because the Corps of Military Police doesn't have any capacity to do forensic investigations. So as an example, the deaths that occurred in Canadian Forces in Afghanistan, their postmortems were all done by the coroner's office in Ontario because we had the most robust capacity in the country. Because the DND does not have any capacity to do postmortems. Once death has been determined and the coroner called, therefore, the body shouldn't actually be moved, touched, examined until the coroner arrives. Section 11 of the Coroners Act. No person who has reason to believe a person died under Section 10, which we talked about already being the circumstances, shall interfere or alter the body until so directed by the coroner by a warrant. So this is the 1990 amendment. Iman.
I just had a question about that as pertains to kids. I know I hadn't been involved in any of these cases, but the cases where kids are determined to be a coroner's case and the parents are wanting after a long recess to come in and hold the baby or touch the baby, technically, from what I understand, that's not supposed to happen, but I mean, that seems pretty cold.
You're exactly right. Section 11 exactly says that. So in those circumstances, what I recommend is call the coroner, get the coroner to talk to as soon as you can, because it says as directed by the coroner. If the coroner says the parent can pick him up, that's okay. But it's not a judgment that you should make yourself. The other implication is to keep the tubes in place, because really this means, so if you have resuscitated and you have, endotracheal tube and a chest tube and everything else, to keep them in place. And this is primarily, to be blunt, because especially in cases of chest tubes and things, the pathologists, if you take the tube out, aren't quite sure if that's chest tube, stab wound, what it is. What's interesting is that death pronounced because people feel the coroner's going to pronounce death. Actually, death is pronounced can be by anybody. Yep, they're dead. The issue is certification's the issue. Because only physicians, coroners, certain nurse practitioners can certify that you're dead. In denial, it's like like the Wizard of Oz, as coroner, I've examined her, and she's not only merely dead, she's truly and sincerely dead. That's the same deal. So this truly and sincerely dead part belongs to either physicians or the coroner. And certain nurse practitioners in places like the North where they're clinical nurse practitioners.
The nurse practitioner thing, do they have to do something different?
There's nobody in London, I believe, that's trained in that way.
No, but in our rural areas.
Yeah, there's a separate process for getting that. Yeah, because there's not too many that actually have that certification. So the final step is the investigation. It can conclude at the scene or it can be ongoing. So some investigations are mandated. So for instance, if you die in an industrial accident, there's a mandated autopsy, there's a mandated Ministry of Labour investigation. If you die in a fire, there's a mandated investigation by the fire marshal, etc. If you do need a post-mortem, there's only one place in the region that does them for the coroner's office, which is here. The morgue is down actually on the ground floor towards that end of the building. The forensic pathology unit does all the forensic ones. There are 3 forensic pathologists here, Dr. Tugleva, Dr. Tweedy, and Dr. Schrum, who's the head of the unit. In terms of condition of body, because every now and then a body will show up in the ER. People think in the usual station they're actually dead. So rigor. What's rigor? That's tissue rigidity in which they're unable to respond because of coagulation of muscle protein. What's interesting about rigor is that the timing of death is interesting because the best way to time someone's death is if someone says, yeah, I was there when they fell over and died. That is scientifically the most accurate way of doing it. All other accurates are unreliable. For those of you who watch CSI, when they throw out into someone's liver, totally unreliable because it's dependent on health, body temperature, ambient conditions, humidity, radiation, etc. So you can't actually predict the time of death based on that. You can make a guess because of rigor, but it depends. I mean, there are conditions in which you actually have immediate rigor. The odd deceased person will go into immediate rigor because it's all about calcium release. So lividity is how the blood settles. And lividity can develop within 20 minutes, and it first becomes blanching. After about 8 hours, it becomes fixed. So that's another issue in looking at death. And there's some other issues as well. So every now and then, something like this will show up in the ER. So does anybody know what that is? Okay, I know it's a gun. Can you be more specific as to what it is? It's a Glock. That's right. Okay, where's the safety? Well, that's a good point, actually, because a Glock, as opposed to the Sig Sauer, which the OPP carry, which definitely has no safety, a Glock has a safety, but it's a tricky safety because the Glock safety is right there. There's an internal lever on the trigger that does it. So it technically has a safety, but really it doesn't. Because there are 2 internal safeties. There's also internal safeties. The firing pin is a safety, but it's also keyed into the trigger. So effectively has no safety. So a gun will show up, and if a gun shows up, it's probably a good idea not to do a lot with it, unless you know a lot about guns, probably more than most emergency physicians do, and leave it alone and let the police deal with this sort of thing. Jurisdictionally, what's interesting is if you're at a scene, there are actually a series of perimeters at a scene. When you're called out, there's actually a tertiary, secondary, and primary perimeter. So the tertiary perimeter is the outside, is that police, the line outside, the line outside the whole scene where the police constable is standing. The secondary perimeter is the immediate environment, and the primary perimeter is on the body itself. And each of them is controlled by the police when you go in. So they can be widespread. This is a homicide at a resort, and you can see the perimeter there is outside. This is a not infrequent event in places that have metros. A perimeter is actually someone leaps in front of a subway train, which causes all kinds of problems. Or perimeter can be out of doors or inside the hotel room, but this is a more typical perimeter in a place like a hotel room. And of course, you get the crime scene guys can come at places like a car crash or again a room. So just talk about some typical cases to sort how we might think about what goes on coroner-wise. 85-year-old gentleman is found breathing agonally in his apartment by his son, brought to the hospital, goes in VSA, resuscitated in the ER. This gentleman is known to have COPD, heart disease, on many medications, had a stroke, 2 heart attacks. Family doctor is not available, and your exam is totally consistent with history. It's probably natural, probably coronary disease and or COPD. So the question is, should it be a coroner's case? Now, a coroner's case should be done in a couple circumstances. Really, if you, as an emergency doctor, you think, is this one of those circumstances people talked about, accident, homicide, etc.? Or is this a case with implications for public health? You don't think it was by unfair means or anything else. So, is it a public safety issue? Not really. I mean, old guys with COPD and heart disease do die. Then the last thing is, do family have concerns? Because that gets to the issue of unfair means. If the family said, well, he was in his doctor's office yesterday, he said he was in fine health, and now he's dead. Okay, someone misinterpreted something. But the family says, no, we know that dad was in bad shape, and I'm not worried, So this would not be a coroner's case. This is a natural death.
When it turns out that's the index case for an outbreak of Legionnaire's disease,
Yeah.
the fact that you didn't call the coroner and you filled out the death certificate as COPD.
Say he was in a nursing home and he was the first person to died. Totally reasonable. If he's the third person to die in one day, then you might think something's going on. So that's a different circumstance. That has the implications of public safety issue. That's exactly right. Different case. So a 17-year-old woman found breathing shallowly in a hotel room by the cleaning personnel, known to be police to have related for drug-related crimes, thought to be in good health, taken to the ER, where despite vigorous efforts by the ER staff, dies. An examination, she's got disheveled clothing, apparent head wound, drug paraphernalia among her personal effects. I think we can all agree that this is probably not a case that we're going to just pass off on. So this is definitely not a natural death. Maybe suicide, homicide, undetermined. So this is most definitely a coroner's case. So it needs a post-mortem, needs forensic examination, etc. So you need to call the coroner, preserve the body. They will come investigate it. There is the question of paperwork. So who does the paperwork? The hospital paperwork you guys get to do, but Form 16, which is the death certificate, that is the coroner's job. Because in this case, to fill out a Form 16 accurately, because the nosologists want accuracy, you need information that you don't actually have. So you need the results of the toxicology, you need the results of the post-mortem, and you're not going to have that in the ER. So this falls back to the case. In the coroner's case, the Form 16s always fall back on the coroner. So if the Form 16 for some reason doesn't show up in Thunder Bay, which is, by the way, in case if any of you don't know, is where all the Form 16s eventually fly to, the people in Thunder Bay will say, where's this Form 16? And they'll follow it up with you. The emerge doctor will fill out the hospital part of it. The medical legal part, the Form 16, defaults to the coroner.
Mike, can I use that as a segue to ask another issue? Because as you know, as emerge physicians, we often see patients try to resuscitate them and have a failure of resuscitation, or they die shortly after a resuscitation. And then the question for us is, where are we treating the right disease entity? Right? And the case becomes a coroner's case for whatever reason, because it fits it's very difficult for us to get those results once it becomes a coroner's case.
It's actually not even legal. Because the issue is, Doctor...
So my question is there any way to
yes.
put this in that loop of information? I think many of us would like to know if some of the death was iatrogenic, or whether there's something else that we should have considered in the process that may have changed.
That's a very good question. Because the question is, because the last iteration of the Coroners Act in 2009 incorporated some clauses from the Privacy Act. So what happened is that previously coroners' death investigations were more widely shared, and now they're only shared with, they go to the investigating coroner, the regional chief, whatever other mandated bodies involved. So if it's a fire death, it goes to the fire marshal. If it's an accident, it goes to the Ministry of Labor, and the family, and that's it. They don't be anywhere else. Now, many of us have argued that this is nonsensical, because for hospital deaths, for quality improvement purposes, it's actually cutting the institutions out. So if there was an issue the hospital needed to know about, then they would know about it. So for instance, say there was a system-wide problem in which the hospital's epinephrine supplier was actually giving them distilled water instead of epinephrine, which would be an issue. There's no way under the Act currently to tell you that unless the regional chief coroner says it's a public safety issue. The workaround is this. If there's an ongoing M&M process with QI, then the hospital QI process can say this is a QI issue, quality improvement issue. We want, as part of our quality improvement issue, to review these results as one of our regular rounds. Ask the regional chief, then the regional chief will say, oh, sure. Then they can ask it. Then you can get those results for that case. So what I would suggest is in those cases, the best thing to do is keep a record of the cases you want to do it as part of the regular QI process. Say we're going to have a QI rounds, quality improvement rounds, and invite the investigating coroner. They'll have to clear with the regional chief, but the regional chief will always say yes. Because, why would they not say yes? There's no downside to saying yes. So let's say yes, and then the regional chief coroner then you can come out and share the cases. That's what we've done a couple of times in pediatrics. We've had some deaths in the peds emerge in which we're saying, well, what actually happened here, right? And the way to share that and actually be legal is to include it as part of the QI process. because that speaks to the issue of public safety, the greater good, because part of the Coroners Act speaks to the issue of issues germane to public safety. So acting on part of the greater good is a QI process is the way to get that. So there's no informal way to do it, but as a formal, well, there's no legal informal way to do it. But as a QI process, saying this is our formal quality improvement process, we need to know these things as an issue of public safety, then it's a no-brainer. The flow of information has gone from being very good information back and forth to just one-sided, and that's not good because then people can't learn.
Is there another way to get around this by actually asking the family for consent?
Yes, the family can share the results with you at all, for sure.
No, I'm saying if they sign a consent saying that the physician or the hospital could have access to the coroner's report, is that?
That would be the family can ask the report to be sent to whoever they want. So yes, I believe that would actually be legit. The family saying, please share the final coroner's report with the investigation. That's the other way of doing it. Some common issues. One of the issues is unexpected death. You may remember the Coroners Act, Section 10 said if death is sudden and unexpected, it has to be reasonable because the Coroners Act is not about immortality. It's about preventable death. Every now and then you get a call like, well, this 94-year-old guy was found dead in bed. He had a stroke and hypertension, but we didn't expect him to die. I've never said this, but I was thought, how long do you expect him to live? It would not be unexpected that a 92-year-old guy who's had a stroke dies in his sleep. That's not unexpected. So unexpected needs to be in a reasonable context. Because again, it's not the Immortality Act, it's the Coroners Act. The other thing is unavailable physician. Because every now and then I get a call because, the family doctor is not around. Technically, if it's a natural death, the coroner has no jurisdiction. Most coroners will see those cases because otherwise they're in a bind. And what is natural? Natural means all natural. If there's something intervening to change the process of a disease, it's not all natural. So, if an elderly person breaks their hip, for some reason orthopedic surgeons say we're not going to operate, they get pneumonia and die, that's not a natural death. It relates to what's called the if-but-for test. So the if-but-for test is if but for this event, they would still be alive and kicking, or at least alive. Then that is what applies. So the best test to apply is when something happens, you say, okay, if except for this happened, then the person still be alive. And it cuts both ways, because every now and then you get a death that event occurred, who was actually already agonal for another process. Okay, what was going on? Well, they had sort of metastatic cancer, and they were dying of that. Okay, if but for this event, would they have lived any longer? Probably not. So as an example, 15-year-old young man comes to the hospital for pneumonia. When he was a 5-year-old, he was in a motor vehicle accident, crashed in a tree, paralyzed, had multiple episodes of pneumonia since, comes in, despite aggressive therapy, his pneumonia gets worse, and he dies. This is actually an accidental death. So the cause of death on the Form 16 would say pneumonia for 1 week and motor vehicle accident for 10 years, because if but for the motor vehicle accident, not too many 15-year-olds have pneumonia. There are distant events, so there are accidental deaths that occur quite distantly from the accident. And I guess in my personal experience, the longest one was 20 years. This 40-year-old guy died, if but for the accident, probably would have still been alive. Amit.
Wouldn't that make then every sort of paraplegic or quadriplegic patient who comes in and dies, it would make them a coroner's case, would it not? Because we'd agree that all of those people...
A good hunk of them, yes.
Yeah, so we should be calling the coroner for all of those people.
I mean, a good hunk of them, yes. It depends. It depends, but technically under the Coroners Act, if you're quadriplegic because of an MVC and you die as a consequence of it, it's technically an accidental death. Which is not something people think about because, okay, a person who's been paralyzed for many years, gets pneumonia and dies, it's natural. It's natural, but what's not natural is the part that got them paralyzed. Unless they had some kind of natural disease that made them paralyzed. Like spinal motor atrophy, for example, that's actually a natural disease.
It's just in terms of cause of death for the other cases where they're natural, we're just guessing, right?
Cause of death is the best estimate.
Best estimate. So a guy that's dead in bed at 92 is...
Statistics say 3 or 4. There's a 80% chance it's a heart attack, 20% chance it's a stroke, 1% chance it's something else.
So 4 times out of 5 I put heart attack, 1 out of 5 I put stroke.
It's best available determination because filling out a Form 16 is best available evidence. It's not intended to be It's kind of like religion, not science. I mean, it's best available. It's what you think happened, not what you could absolutely prove.
In that case, on the 92-year-old, if the family said, he just married a 35-year-old hussy and we know she gets
That's CSI here.
That's a coroner's case.
Yes. If the family says, that's exactly the coroner's case, because they say, oh, your dad married this young vixen, she's a coal digger, and we think she did him in. Yes, that's exactly right.
Too many 4-year-olds in that situation, but I thought I'd clarify for the adult group.
Think of those cases to consider. We talked about those cases at the start. The elderly gentleman who's out driving with a history of heart attack and a stent and collapses and dies of ventricular arrhythmia, almost certainly not a coroner's case. So unless he had a stent the week before and his spouse says, oh, I think they put the stent in wrong, backwards or something, then otherwise it wouldn't be a coroner's case. The 8-year-old, you could make a case it's not a coroner's case. He says, oh, it's probably meningococcemia, it's a natural disease. 8-year-old dies of meningococcemia, it has public health implications, you probably should be a coroner's case. There are a couple common myths that apply. This is one myth that drives us coroners crazy, which is not a far drive for a lot of us. But call for any death requiring X hours of hospital admission. This is a cherished myth that our nursing colleagues have. To be fair to our nursing colleagues, there are places in Canada where this is the truth. There are provinces in Canada that say any death within X number of hours is a coroner's case. Not true in Ontario. Now, you remember from the Coroners Act, Section 10, did not mention anywhere in the word hospital admission there at all because it doesn't. So you can be in a hospital for 24 seconds or 24 years. There's no actual intervening time between hospital admission or procedures, for that matter. So if you're in the OR, a 75-year-old gentleman, instead of being in a motor vehicle accident, was having a cabbage performed and dies 2 seconds after the procedure or 20 years after the procedure, there's no mandate. It's not a mandated coroner's case in either event. Now, that all being said, at this institution, there are certain people who think that there are certain people who say, well, we'll have to call any coroner's case with it because it's a hospital policy. I mean, coroners don't set hospital policy, but I can tell you right now, if that's the only reason to call, it's not going to be a coroner's case.
So Mike, in those cases, so if there is a surgical procedure or procedure done, and there is a bad outcome, patient dies, the only time that it would be considered a coroner's case is if the family had concerns about the medical care, or if I had concerns.
Yeah, like if you said this patient went up for an appendectomy and came back and had this big scar across his head, then that might be a reason for that. But no, I mean, if you remember from Section 10, malpractice and misadventure are mentioned. So if you think if the family or you or anybody thinks that there was a misadventure, a malpractice issue, then yes, that absolutely is a coroner's case. Amit, and then...
It's a question for you and for Gary or people who might know our policy. Like I've had that exact situation where I was working once at 1 a.m. and a patient died. It was a natural death, and the charge nurse, who was very experienced and a very bright charge nurse, had already gone ahead and paged the coroner, who I believe was you. Correct. At the time. And I said, why'd you page the coroner? And she said, well, it's our hospital policy for this whatever situation. I said, well, it was an expected death. It was like an 80-year-old or something. I said, we shouldn't page the coroner. I said, I'm going to have to deal with Reider now. And, so you called. You were very gracious about it. But anyway, she had this big discussion with me that this was hospital policy. And I said, there's no policy like this that you're not aware of it either.
There is no policy that dictates who needs to be contacted for what. But remember, under the Coroners Act, just for a second, we take it back. If they had suspicion, they are entitled to call the coroner. Right. Anybody can call the coroner. That doesn't. But the issue that this is policy is not correct.
It's been practiced.
It's practiced.
For many, many years. It was a routine to simply, patient dies, call the coroner, have a chat, and then if everybody agrees this is not a coroner's case, sign it off. But that doesn't need to take place.
It's not policy. It doesn't have to.
In my experience, it's gone one step more, where if the police attend, just because they got called for a collapse or what have you, but if the police are in the department, they almost insist that the coroner be called. And if you fill out the death certificate and fill out all the paperwork and say, look, this is all natural causes and you were just there for non-concerning reasons, I get calls the next day from the duty sergeants and everything else saying, who was the coroner he spoke to, who was like...
That's true. If the police are involved, they want to get it cleared by a coroner. And that is their policy.
That's even if they get called for...
Anything.
Yeah, anything. Even though there's no suspicion.
And on the other side of it, I see what happens is that, like if they get called to a house and it's a clear natural death, they still have to stay there until a coroner comes, clears it, and then someone comes picks the body up. So LPD spends an enormous amount of manpower on doing that.
They'll stay at the house even though the body's transported to the hospital for potential resuscitation, and they will still have someone at the house. I've said that it's a natural death.
Yeah.
And so that's the problem, is releasing, I think, the house,
Right.
and then that's when you get all these phone calls.
No disrespect, but those guys don't trust people who don't carry badges.
So you must get calls about those.
All the time.
Yeah.
Yeah.
In which case, you just talk to the doctor and then make it go away.
Yeah. So,
I mean, you told us that there are 80,000 deaths and about a quarter of them are investigated.
Yeah.
So presumably 75% of the time you're getting a call, or a coroner is getting a call, or having that discussion.
Yeah.
And that's a perfectly legitimate phone call to make if you have any doubt.
If you have any question about it.
And for many physicians who don't do this very often, any death is, well, I better just call just to check.
Yeah, no one's going to fault you for calling him. I mean, the coroner might be a little grumpy or ticked off, but no one's going to fault you for calling him. On the other hand, if you don't call the coroner, and it's in this coroner's case, people call you all manner of bad and wicked things, and et cetera, et cetera. So it's not going to hurt you. There was a question back there.
Can you just comment a bit on the nuts and bolts of, okay, so the coroner decides to investigate. What does that actually entail?
Coroner's investigations, that's a good question. So what is a coroner's investigation?
What falls to you versus the pathologist? And things
Okay,
like that?
so if you investigate, so I decide, okay, let's take the 8-year-old, for example. Okay, this is an 8-year-old, so what does it involve? So the death investigation in that case is going to be a post-mortem. Probably visits the house by me. The police will be probably. So getting some medical records from the physician, from a deceased physician. So sending a warrant out to get those medical records. The next day, having a chat with talking with the pathologist about the post-mortem examination. And it may wrap up with that, waiting for some lab results to come back. If the 17-year-old, in the case of the 17-year-old found in the motel room queer drug abuse, then it's looking for the toxicology results. It's talking to the police. It's probably having a case conference 3 or 4 weeks later to sort out what's going on while the police do their investigation. So the investigation involves sort of going out and seeing a bunch of things, which has implications. Because if a coroner is, and that's one of the reasons we try to be a bit, when we're looking for the question of what calls we take and what we don't, to get a coroner to triage a case and sort it out costs the system about $100, roughly, if you factor everything, all the costs in. If the coroner actually goes out and looks at the case, it costs the system about $600, and that's where it starts. If you do a post-mortem full investigation, the meter goes up to about $2,500 and just starts running. So there has significant resource implications for the system as to the ones we investigate. But a full-bore death investigation is actually a lot of work.
So if you're working part-time, then I assume you're responsible for the cases that you take on.
Correct.
So that can be quite extensive, depending on the
Can be
case.
extensive, yeah. Yeah, coroner's work, no one gets rich doing coroner's work, I'll tell you that right now. I mean, I do it because I like it, but it's not the way, unless you become a regional chief coroner, but except for that. Oh, okay, same thing about procedures. You may remember that no procedures are stated in the Coroners Act, and that's because there's no requirement unless you think something happened.
If they've had recent surgery, they have but for. So somebody develops pneumonia, they just had inguinal surgery, but you said if they hadn't have had surgery, they wouldn't have got pneumonia.
Except that pneumonia post-operative is a known complication of that procedure. So I mean, it's worth, in that case, further to John's point, it's worth discussing with the coroner probably, and the coroner may say, listen, this old guy had pneumonia, had a hernia procedure, but it's no complication of hernia procedure, old people to get pneummonia, so that's a natural death.
If it was a younger person,
then it's definitely worth the conversation, and it may be worth investigation. So yeah, so it was say some 36-year-old guy comes in, gets pneumonia and dies post-procedure, that's probably going to be a coroner's case. No, the courtroom work is mostly done by the regional chiefs, because the regional chief coroners, the full-time guys, do most of the court work, with the exception of, I was called to court once because I was the one that actually found the murder weapon. Because there was this lady who got killed, taken off, they put the brace on, put him away. I look around the house and I'm saying, well, where's the murder weapon? And the detective says, oh, yeah. So we looked around and I found it. It was he had actually put it back in a drawer in the kitchen. Autopsies. There's a myth among some nursing staff that you have to have arrange an autopsy. In point of fact, medical staff too. In point of fact, anybody, you guys can arrange an autopsy, hospital autopsy, no problem at all. And in fact, a hospital autopsy doesn't require consent. Technically, a coroner's autopsy is only shared with the family. So if you want to actually know the results and there's no coroner's issues involved, get a hospital autopsy because you guys can access hospital autopsies as part of the circle of care. So the take-home message, the coroner is responsible for determining cause and matter of death. One thing to remember is that the coroner's role is death prevention. We're involved in criminal deaths. The police do that, but we work together as a team to sort those things out. One caution, don't promise something you can't deliver on. If the coroner decides an autopsy, the family has no choice. It will happen. If the family says, will there be an autopsy, the best answer is I don't know. Because you don't know. Because as an example, some of these autopsies, I don't have a choice. If a driver dies in a car accident in Ontario, they will have an autopsy, period, full stop, because that's what the Act says. If a person dies on a railroad track in Ontario, they're going to have an autopsy, period, full stop, because that's what the Railroad Safety Act says. And I have zero jurisdiction to say no. So that's important to understand that while the families have a choice, sometimes the coroner does neither, actually. John?
How does the coroner decide whether or not passengers in a vehicle have an autopsy?
Good question. It's based on, because there's no requirement for it, it's based on the judgment of the coroner and as to what other circumstances are. To be honest, I tend to actually do autopsies when anybody dies in a car, but and a lot of us do it that way. That all being said, it's actually becoming, with medical imaging, it's becoming sort of less and less of an issue because now, with the head-to-toe CT, you can, MRIs and everything, you get a pretty clear picture in most trauma patients of what actually happened.
In a rural environment, that's not always the case, though.
Correct. So in those settings, then then most people defer towards caution, especially the circumstances in which there's a male driver, a female passenger, and the driver survives. Those cases pretty much all get autopsies because
So there's a difference between a female driver, a female passenger, and a male driver, a female passenger?
The issue of intimate femicide is a big deal with the coroner's office nowadays because there have been a couple high-profile cases in which people have attempted to conceal the fact they did in their wives by getting in a car accident. So that's actually a hot-button item for us. I mean, the coroner system, again, the coroners, I think the take-home out here is that most deaths are not coroner's deaths, but especially in the ER setting, a good hunk of them are. When in doubt, just ask. If you're in doubt, ask, because no one's going to fault you for doing it. I think there are certain things that happen that are just irritants to us, like this whole calling because the death occurred within X hours of admission. But something that's just an irritant. It's not a block. And I think really what I would say is the emergency doctor and the coroner need to have a good relationship because I think we're sort of mutually behind the same goal of better outcome.
Comment on the impact or power that a coroner's inquest holds in terms of the reports that get released. I've had to review 2 of them recently from the pre-hospital arena, and direct one was around STEMI care, and it seemed that the results of the inquest were less than evidence-based in terms of the recommendations.
There was a coroner's inquest. Coroner's inquests are not at a coroner's inquest. The coroner is the presiding official, but the inquest jury make the recommendations. So the quality of the recommendations from the inquest is proportional to 3 things: the presiding coroner, the evidence presented, and the people who are sitting on the coroner's inquest.
Also, the one thing I found is the geography comes to play. So if it's a case from Toronto, the inquest surrounds is very different geography than Chatham, and
it's a very different population of people because the population of people that can devote 2 weeks to sit and listening as a coroner's jury in Toronto is very different than it is in Chatham.
With respect to clusters of cases, a certain surgeon has had.
Right.
Normally, there should be a QI process,
right.
Infection rate, higher death rate, what have you. If you were called about a case that the family was concerned about and you investigated, would there potentially be then, become the coroner's office job to actually look at this individual's practice, or
if it's a death related to quality of care and the family requests that issue, then the investigating coroner will kick that up to the regional chief, because the regional chiefs do have a mandate to actually investigate this for public safety. So that the process that Gary described will then swing into place. Will say, well, listen, it seems to me there's a concern about Surgeon X, and all these people dying after getting their cataracts done.
And who's saying this?
The regional chief coroner.
The regional chief. Okay.
Yeah, and they will sit with the chief of staff of the hospital and say, what's going on here? And they'll have to generate a response which satisfies it. And from that point of view, the coroner has actually shut down various programs in the province who said, listen, that's an interesting response. That doesn't work for us. You've got to stop doing this. And while the coroner's office has no, we don't they don't have the mandate to actually go and say, walk into the hospital and say, stop doing this. The cold hard reality is, the cold light of day, no hospital CEO is going to continue a program that the coroner's office says is unacceptable for public safety. So there have been programs in the province, there have been surgery programs in this province shut down because of that.
Last question.
Sure.
I should know the answer to this, but there's a patient safety review committee out of the chief coroner's office.
Yes.
And how do cases get referred to that committee?
They get referred by different sources. The common referring source is regional chief coroners, because a coroner will say, this doesn't seem right to me. Talk to regional chief says, this doesn't seem right. We'll kick it up. Common source is that, but it can also come up from hospitals, or to be blunt, if
seem right from what perspective? That we need an inquest, or why would it go to the patient safety review committee?
The patient safety review committee, the issue is inquests, as we talked about, are driven by our public events in which the public does make recommendations. If the regional chief coroner thinks that this is something that needs actual evidence-based or specialty input, then it goes to the patient safety committee. It's the same reason why the Death 102 committee is a specialist committee rather than having inquest, because they need specialist input. Same as there's also a separate thing for like industrial accidents, because lay people, with all due respect, probably don't have the expertise to make the recommendations needed to drive public safety in those areas. Okay. Well, thank you very much.